invite Dr. Sangeet Mittal for the first talk, uh, Tips and Tricks in Management of Diabetic Tractional Retinal Detachment. Dr. Mittal. So Dr. Mittal is a well-known surgeon from India, known for his brilliant, innovative surgical tips. So looking forward to hear from him. Dr. Sangeet.
Thank you, Ritesh. Actually, I have a different session going on, a parallel session, so I have to rush early. Thanks a lot for that. So I'll be presenting on Vitecmi for PDR, what I do different. And the first tip that I would like to give is to creating the plane by causing separation at the disc. And how we do it is just hold with the forceps and just separate the membrane from the disc. And you get an accurate plane from where you have to proceed for the further vitrectomy procedures. So this is how just remove from the disc to get the plane. Second is what I do is around the table dissection, and what does around the table dissection means is like I start by lifting the membrane at the disc, then I create a wedge by cutting the retinal tissue and advancing to the periphery. Once I've done that, I induce the PVD in the periphery, and then I keep on moving around all these epicenters, taking them one by one. I can go from outside to inside and inside to outside, both at the same time, making the surgery easier and faster. And because I've started at the disc, I've got the right plane, and I have induced the periphery at the PVD at the periphery. So I just have to go around these epicenters. So we don't need to cut through them. We just go around them. So this is how, and I use the minimal possible gauge cutter which is available, and that helps me to cut these membranes with the cutter itself. So this is what is around the table dissection, and you can do most of your surgeries using this technique. So this around the table dissection can be performed in all types of TRD. You will get the good plane because you start at the disc, and it reduces the surgical times, it has lower complications, and it is easier to perform. Second, membranes are not missed and need not be dissected separately. You hardly need any fourth port when you are doing by this, and this can be performed in all cases, mostly all cases. So I use the smallest gauge vitrectomy because it gives me a lot of advantages. You see here I'm using 27 gauge cutters, and I think my primary indication of using 27 gauge vitrectomy is in the diabetic TRDs. So you see the cutter, it enters even the very small places, very small distances that are present between the two nails, and you can just cut through them. And even your cutter can go in between your retina and the pre-retinal membranes, so you can just lift them and then cut through them. And these definitely have small, low sphere of influence. You can, with the cutter only, you can, even in detached retinas, you can easily, detached and mobile retinas, you can separate the membranes and eat them up with the cutter itself. So this is my third tip. Use the smallest gauge possible which is available to you, and you'll find that it helps in most of the cases. Now, another thing is that don't shirk to use the biomanual, so use them whenever they are needed. And I don't use the scissor, I generally use the needle or I use the cutter itself. I'll just show you one video how I use the needle. Sorry, is this video. Yeah. So this was a 48 years female PDR with tabletop tractional detachment, and vision was PLPR. So you put in a chandelier, and I started bimanual from the word go. Just lift the membrane and just use the needle to slice through these vascular nails one by one, and keep on lifting the membrane here. And this needle, it just cuts through these nails. Just have to make a to and fro motion, and the advantage is like with minimal difficulty, you are able to get the whole of the membrane en bloc. And even if you can use your needle in your non-dominant hand, because the action that you are doing is not very difficult. You just have to move your hand to and fro, And once you have got rid of most of the membrane, you just have to use the cutter to remove the membrane. So with just a small 25 gauge or needle, you can use the cut. You can remove the difficult membranes. And I also have devised a instrument which I call AIOS, and that can be also used. So take in consideration the red flag sign. And what is the red flag sign? What I call the red flag sign is the presence of any loose peripheral blood which remains even after you have completed the vitrectomy. Sometimes, so we just tend to ignore it, but it's not the thing that is to be ignored. So here you see I started again at the disc. I created a plane of dissection. I have removed most of the membranes. This is again a PDR with combined retinal detachment. And once I have removed the membranes, I completed my vitrectomy. I think I've done a very good job, but what remains is there is this peripheral blood which is still hanging in there. So it is not the thing that is to be ignored. You see the amount of vitreous still left. So this peripheral blood gives you a sign that there is still vitreous cases is there. There is still a layer of blood, there is still a layer of vitreous which is still remaining. So don't ignore it. You have to go in and you have to take care of that. You just have to remove it. Another question I've many times been asked is like, what if you have done your TRDs and you didn't create a break and still there's a lot of fluid, what will you drain it, or will you leave it like that? So I generally don't drain it. I use gas to flatten the retina in those cases, just like you do it for your submacular hemorrhages. So in this case, you see again, sorry. Yeah. So this was another patient around another 40 years female. She had this bad TRD with vitreous hemorrhage. So we were able to dissect all the membranes without creating a break. Here you see I'm now doing an ILM peel, and you see the retina is lifted from there. Is a lot of fluid still left in there. So what I generally do is, because this fluid takes months to go and the patients become very anxious in their follow-up period if you let it remain like that. So what I just do is I just inject a small gas bubble and then give a prone position to the patient. This is 1 day post-op. You see the retina has flattened, the fluid has moved to the periphery and gets absorbed sooner. And this is 6 weeks post-op. The patient's vision had improved to 6/9. And this works for me very nicely. Then another thing that I do different is on the top dissection. So once you have removed the attachments of a tough membrane which is lying very close, you just remain on the top of the membrane and do this modified rollback, moving closer to the edge of the membrane again and again, and the membrane will automatically, and you have to use a full throttle, you have to use highest possible suction. The membrane just inverts and comes into your cutter without causing any harm to the retina which lies below. So you have to remain on the top of the membrane, and slowly you have to just dissect it. Thank you.
Thank you.